presentarles al doctor David Cornblath. El doctor Cornblath, como les decía anteriormente, es profesor de la Universidad Johns Hopkins, profesor de neurología. El doctor Cornblath no es ajeno a Colombia. Él participó en las reuniones en el 2016 y en el 2018 de la Asociación Colombiana de Neurología y ha sido un colaborador excelente para las actividades de investigación en Guillain-Barré. El doctor Cornblath es muy reconocido a nivel mundial por sus investigaciones en neurofisiología de Guillain-Barré, diagnóstico de Guillain-Barré, y desde los años 80, 90 ha sido uno de los pioneros en investigación y tratamiento de Guillain-Barré. Voy a introducirlo en inglés por un momento. Dr. Cornblath, thank you so much for joining the meeting of the Neurovirus Emerging in the Americas. It's a great honor to have you here today. We appreciate very much all the dedication and collaboration that you have given to Colombia. We know that you have been in Colombia at least twice in the past few years. And we appreciate that spirit of collaboration. Welcome to the NEAS Grand Rounds, and thank you for everything that you have done for us and for Colombia as well. Welcome, David.
Carlos, thank you very much. And it's great to be here again and to be virtual, although I'd rather be live with many of the people I probably can remember from my other trips where we work so collaboratively, frankly, to get an extraordinary paper published in the New England Journal of Medicine. Not a small feat by any stretch of the imagination. So again, let me thank you. And this is the title slide. That's from the original publication. There we go. These are my conflicts of interest. And when I was given the topic, diagnosis and management of Guillain-Barré syndrome, I said, well, I don't actually need to do anything. I just will refer to this really extraordinary paper that was, as you can see, written by a large number of people. You can see Carlos's name somehow got big. I'm not sure why. This is bigger than the others, but you can see that there are a number of experts from around the world, all of whom participated in writing in this very nice, easy to follow paper. Sonia Leonard, who just was the first author, actually got her PhD yesterday in the Netherlands, in large part based on this very excellent paper. So I say, if you want to learn anything, you can just read it in this paper. And let me just show you. There we go. This is one of the tables from the paper. You can see that it's really been set up so that it's meant to be a working paper, when to suspect, when to diagnose, all elements about acute care, and then about the long-term care. Every aspect has been dealt with very efficiently in this paper. So I'm just going to briefly say just a few things because many of the people have seen many, many cases and don't need a lot. These are the features that are required for diagnosis in almost every set of criteria for GBS. Bilateral progressive weakness of arms and legs, usually it starts in the legs in a so-called ascending pattern, but can be a descending pattern. Absent or decreased tendon reflexes in the affected limbs at some point. These are the features that support a diagnosis. I'm not going to read through them. You can see them yourself. The important parts are the last two bullets. That is an increased protein, which was part of the initial criteria by Guillain-Barré and Stroll. We now know that up to a third or more of the people with GBS will have normal protein levels, particularly in the first few days. So it doesn't rule out the diagnosis. And again, similarly for physiology, we know that normal electrophysiology, particularly if you don't do H reflexes, can be seen in the first few days. And that's why H reflexes are a very important part of the early electrophysiology of GBS, because they're almost always abnormal and help show that it's a peripheral neuropathy. There are a couple of papers that are put together to have features that cast doubt on the diagnosis, and just recently was presented at the Peripheral Nerve Society meeting in Miami, a paper from a study that's being done in the Netherlands called GBS Mimics. It's an unusual paper, an unusual study in that if a patient is seen in an emergency room and Guillain-Barré syndrome is anywhere in the differential, they get put into this study. But let me at least show you the clinical features or laboratory features. Obviously, infectious causes are suggested by increased numbers of cells in the spinal fluid, although we do know that a confident diagnosis of GBS can be made in people who have more than 50 cells. Marked persistent asymmetry is highly suggestive of polio, and if one looks at the old polio virus or even the current polio virus WHO criteria, this is one that would strongly suggest polio, along with fever at onset, which again strongly used to suggest polio. We now know that there are other illnesses such as coronavirus or Zika that also can appear to have a fever at onset. There are a number of features that suggest spinal or CNS causes, bowel or bladder dysfunction that are really persistent and significant, sharp sensory levels, hyperreflexia, upgoing toes, and of course, an alteration of consciousness. And then there are a number of features that suggest other disorders. Severe respiratory dysfunction with limited weakness at the onset suggests a primary respiratory illness. Sensory signs with limited weakness suggest acute sensory neuronopathies. Very rapid onset is not seen in Guillain-Barré syndrome. Abdominal pain suggests porphyria. Slow progression suggests maybe CIDP or acute onset CIDP. And then obviously, because of the definition, continued progression for 4 weeks, greater than 4 weeks after the start, just by definition isn't Guillain-Barré syndrome. And so from the literature and from this Dutch study, we can see what actually looked like Guillain-Barré syndrome was diagnosed with Guillain-Barré syndrome, but wasn't. And you can see that the numbers are pretty low. In the IGOS study, from the first 1,000 inclusions, there were only 6% of people who didn't have Guillain-Barré syndrome. You can see the vast majority of them had acute onset CIDP, which you could never set apart in the first days to week. Other peripheral neuropathies, and personally, I've seen quite a number of this during the COVID time, at least in my country and in my area. People got heavy into too much alcohol and not enough eating. So there are people who presented with acute alcoholic or nutritional neuropathies. CNS disorders happens all the time. Spinal disorders is frequent. If one looks at the recently published SID-GBS study, which I'm going to talk about a little bit more in detail later, only 2% of the people didn't meet the inclusion criteria, which were those of a clinical diagnosis of GBS. However, if you look at this funny Dutch GBS mimic study, that is, again, GBS is somewhere in the differential, could be down number 10, or it could be listed because a resident felt that they wanted to be complete. They claim that 43% didn't have GBS, and you can see the list of causes from infectious to metabolic to post-infectious. But again, it's an unusual study because the inclusion criteria are so loose. So what I'd like to actually spend most of the time talking about is treatment. And over the many years that I've been involved in GBS, I've decided to think about this in sort of a more simplistic fashion. So simply put, everybody in the field thinks that GBS is an autoimmune disease in which there's a specific trigger. The best known and studied is C. jejuni, but there are many others, including Zika virus. And these lead to a process of molecular mimicry toward peripheral nerve, but only in susceptible individuals. So if you will, a family gets GBS, only one person will get, family gets Campylobacter, then only one person in the family will get GBS, or if 1,000 people get Campylobacter, only 5 or 6 will get GBS, because it does take, as I say, 2 to tango, or a fallet à deux. That is, you have to get the right trigger. We know that all the Campylobacters don't trigger GBS. There are specific ones that do, and you have to have the right host to be able to develop this process of molecular mimicry. So once the molecular mimicry starts, we know that antibodies are important, and if you will, they're the main cause or the effector mechanisms of GBS, and that interfering with them is what current treatments do with a moderate degree of success. So if we think about GBS, this is a slide that I showed, as I used to joke, for people in our elected government in Washington who need things extremely simple. We know that plasma exchange is as good as IVIG, and that if you get plasma exchange, then IVIG, there's no improvement or there's no better outcomes. And you can see that in the slides on the right from the so-called plasma exchange sandoglobulin study seen over there, where the three curves of IVIG, plasma exchange, and plasma exchange, then IVIG, essentially overlap in terms of their time to recovery of walking. So if you go down a little bit further into the weeds, we know that from the North American and the French studies that plasma exchange was allowed out to 4 weeks. I can tell you that in secondary analysis, those randomized within a week of symptoms did better compared to the controls randomized within a week, and those randomized after 2 weeks of symptoms did better than those controls. But that those randomized in week 3 and 4, although they're better, the difference was smaller, although because the study was out to 4 weeks, the whole population did better. So as a result of this paper, the other studies that have been done essentially said, well, we're going to only go out to 2 weeks because the difference out in 3 or 4 weeks wasn't that great. So in the IVIG studies done by the Dutch and then subsequently by Richard Hughes and the sandoglobulin studies, all the treatments were given within 2 weeks of onset. So if you want to be precise, if you have Guillain-Barré syndrome and you're on disability grade 3 or worse, you can receive plasma exchange up to 4 weeks after onset and be confident that you'll do better than if you didn't get treatment. If IVIG is going to be given, we can say, well, you can give it up to 2 weeks and you're going to be better, but we really can't say for confidently whether you do better if you're given IVIG at week 3 or 4. So this has led a little bit, in my view, to a bit of over treatment. That is, people go, well, the earlier you give it, the better, therefore we'll give IVIG. And maybe a week later, they say, well, actually, it wasn't Guillain-Barré syndrome, or in some of the patients that I personally see, when I see them 1, 2, and 3 months after Guillain-Barré treatments, I can say, no, I'm not sure why you got it. You didn't have Guillain-Barré syndrome. However, I can see why your doctors gave it on day 2 rather than waiting for 3 blood tests, which took a week to come back. So if we think about the mild data, mild patients with GBS, really it's from this one French study in which 2 plasma exchange treatments were better than none. You could return to normal faster, but there wasn't really much benefit. There's no specific data on GBS, but the IGO study is going to provide some on what happens if you get IVIG in mild GBS. Very interestingly, in my view, in Fisher syndrome, there is absolutely no trial data. And in fact, the best study, in my view, is a large retrospective Japanese study that suggested, yeah, like 2 plasma exchanges in mild GBS, you get better a little faster. There's really no substantial advantage over the longer run, that 1 or the 3 and 6 month time. And so why give a treatment that's very expensive when people are going to do well anyway? In a lot of cases that are called Fisher syndrome, they're actually Fisher syndrome GBS overlap, but in those syndromes, the GBS severity should determine the treatment. One thing that comes up frequently, and that's why I make a special point of it, is in this online thing that's called Up to Date, which I personally now consider, quote, out of date, close quote. They claim you can give IVIG over 2 days and get the same. But if you actually, again, dig into the weeds, you find that this is from a very small study in children of about 50 kids, in which there was no difference in outcome between the roughly 25 randomized to each group. But we know that in Guillain-Barré syndrome, it takes hundreds to find a difference between a treatment and 2 different treatments. So they said, well, if we give it in 2 days versus 5 days, in 50 kids, it doesn't make a difference in outcome, not unexpected. But if you look into the data, those who got it in 2 days, there were either 5 or 6 relapses in the 25, and there were none in the 5-day group. And so please don't give IVIG over 2 days. You're going to come into relapse, and then you're going to say, oh, there's a relapse, we'll have to treat it again. And so you give 2 times the expensive treatment when you could have gotten away with just a single course. So to think about treatment moving forward, despite IVIG at its standard dose of plasma exchange, it's not perfect. 2 to 5% die, 15 to 20% are unable to walk independently, and that's really in the best hands anywhere in the world. In fact, we still use the dose of IVIG in the regimen of plasma exchange that was developed long ago without any dose-finding studies, and really nobody knows whether more plasma exchange is better, less IVIG is just as good, or actually we should use a bit more IVIG at the first go. People just don't know the answer to these questions. Treatment's expensive. Many places in the globe you can't get IVIG or even plasma exchange, both of which in most countries cost about the same. But there are really a lot of good ideas out there. So one of the common questions is, what do I do when the first treatment fails? Well, this is a difficult question because first, what is a failure? Well, I think people have in their mind that if you give IVIG or you give plasma exchange, it's like a Lazarus effect. And if you're on a ventilator, you get plasma exchange or you get IVIG, you should just come off the ventilator the day the treatment is stopped. But we know that that's not what happens, because clinical trial outcomes were measured at 4 weeks, not at 1, 2, or 3 weeks. So defining what's a failure can be extremely difficult. And particularly when you talk with families, one needs to be very cautious as to whether a treatment was working or not working. If you gave plasma exchange first, we know you shouldn't give IVIG because it's no better than either alone. That's from the plasma exchange globulin study. We now know, and I'm going to show you the details, if you give IVIG first and there's either no response or continued worsening, please don't give more IVIG. That comes from the SID-GBS study. If you gave IVIG first, it's not uncommon that somebody, say, transferred to Carlos at Hopkins, and they say, well, we gave IVIG first, patient's getting worse. Please do something. We know you can do plasma exchange. But Carlos goes, well, wait a minute. If you just gave $10,000 worth of good stuff, do you want me to take it out? But really nobody knows the answer. And then if you gave 1 round of plasma exchange, maybe I should continue it up. But again, this has never been studied. So there, just in this slide, in the previous one, there are a lot of ideas that could be practically trialed without a lot of expense. So I'd like to talk for a moment about what I think is a very important study, the SID-GBS study, or the second immunoglobulin dose study run by Peter van Doorn in the Netherlands. This was a study where all patients with GBS in 60 hospitals participated. They got their standard IVIG, and then they were checked for their prognosis on day 7. And so if you had a good prognosis by the modified EGO study, the Erasmus GBS outcome score, you were randomized to a good prognosis and you received no additional treatment. However, if you were found to have a poor prognosis, you were then randomized and you got either a second dose of IVIG or no second dose of IVIG. And then there was a follow-up, as was typical for all the GBS studies, 4 weeks later is the primary endpoint, with follow-up at 8, 12, and 26 weeks. So this study, of which I'm going to only show you the randomized component here, has all this incredible data over on this part about all these patients who actually did well, and data has been collected on all of them. So here's the primary outcome, was the GBS disability score. Everybody knows that it ranges from 0 of normal to 6, which is dead. 4 weeks after inclusion, there were a number of pre-specified secondary outcomes, as you can read here. These are the rather typical things that have been done in Guillain-Barré studies since the beginning. So you can see what happened. Let me just move. Yeah, there we go. So it took a while. This study was done over 8 years, 339 people, of which, look at the number, most, in fact, had a good prognosis. So it's only about a third who had a poor prognosis among the Dutch. And of those, 13 were excluded for these various reasons, and 99 were randomized. So in Holland, which has 20 million or so folks, it took 8 years among 60 hospitals, all of which had participating neurologists, to do a study to find 100 people that could be randomly allocated to either getting another dose of immunoglobulin or placebo, and then followed up. A few were lost, and then eventually almost 100 analyzed to see what the effect was. So here they are. You can see that for the most part, they're pretty equal. The age is slightly higher in those who got the second immunoglobulin dose, 66 versus 59. And you can see that a few more of these had preceding diarrhea, which is usually a factor associated, which is a factor associated with a poor outcome. But otherwise, there's nothing here in terms of the number of males, their disability grades at entry, their MRC sum scores at entry, how the nerve conduction studies were classified, how many had positive Campylobacter. Again, a bit more here, reflecting that more had diarrhea here. Positive Campylobacter, again, associated with a slightly worse outcome. Anti-ganglioside antibodies, pretty similar. Change in IgG levels, which was thought to be important from a prior Dutch study, about the same, in fact, maybe a teeny bit higher in those getting the placebo group, and the serum albumin, again, a factor suggested in prior studies as being associated with poor outcome, not particularly different. So this is the data, and there's just nothing here. Adjusted odds ratios all cross zero. So there's really no difference. Primary outcome measure, GBS disability score at 4 weeks. You can see they're identical, and all the secondaries are essentially identical. So we can conclude that a second dose in those with a poor prognosis wasn't better than placebo. And here's another way of looking at it in these propensity scales. You can see what people look like at 4 weeks. Here's the number of 5s, the number of 4s, 3s, 2s, and 1s. And you can see there's essentially no difference. Yes, there's a few more 2s here, but a few less, and a few more 3s here. But otherwise, the distributions are essentially the same. However, adverse events seem to be greater in the double IVIG group, shown here in the double red. You can see more pneumonia up here, the ones that are probably related, more trouble with needing a blood transfusion, kidney failure, some cardiac arrest, thromboembolic episodes, TIA, a number of things related to probably the total amount of IVIG given. And you can see where these begin to occur. These probably related ones are all beginning about 10 days, 2 weeks. And that would be, remember, IVIG for 5 days, re-randomization at 7. So finishing the second treatment at about day 12 or about this midpoint. And then you see these. So the conclusion from the importantly done SID-GBS study is it didn't show a significant important difference in benefit of a second dose after a standard dose, probably related to this. That is, earlier studies also found that additional immunotherapy, remember I told you IVIG after plasma exchange, or IVIG with methylprednisolone later, or in the general population wasn't better. It probably means that these are given too late in the disease. So where are we? moving ahead, as I now say to Carlos, if I come into my own hospital, I'm going to call you, you're going to be the attending, and here's what I would want if I got Guillain-Barré syndrome. I would want you to give me plasma exchange on day 1 and 2 or day 0 and 1 after you made a diagnosis. And then I want you to give me IVIG because I'd like to try and get all the bad autoantibodies out of my system. And then I'd like you to cover me over with modulating antibodies from other people's IVIG. And that way, I'm hoping I can cover both bases, cover them quickly, and that's what I would like to do for myself. So you're going to hear a little bit of this coming later in a moment, but that's just a personal preference. So what are the things that are sort of in the works? Well, one of the things is this so-called small volume plasma exchange that's been worked out a lot in Bangladesh by the group at ICDDR-B. And so, as I told you, plasma exchange is expensive. IVIG is expensive. So they came up with the idea that what they would do is they would do what's called small volume plasma exchange. And here's essentially the answer. You take somebody, you lie them down, you draw out their blood, you hang it up in a room if you can't get it to a blood bank and spinning, and then you get rid of the plasma. So it's essentially what's done in a plasmapheresis machine, but you don't need the machine. So it's a small kit. You can do this multiple times, either every day, multiple times in a day. You can do it several days in a row. And you can essentially do this small volume plasma exchange with a kit that's considerably simpler. So this was done in Bangladesh with a small number of patients. And you can show that it's feasible. You can get more than 8 liters of plasma exchange. Was reached in 3/4 of the people. That's a number comparable to plasma exchange machines. There's the usual sort of problems that are relatively minor associated with drawing blood on people. This is a Kaplan-Meier plot, shows the confidence intervals around the people who got better. But again, this is a non-randomized trial. So the conclusion was that, it's safe. It can be done in low-income countries. We're trying to get some funding for a randomized placebo-controlled trial in which some people would get this versus other people who wouldn't. Because if this became popular, or we could show that it was tolerated and gave good results, it could be done in many other parts of the world. And what I learned after going to Bangladesh is that, in fact, in Myanmar, this is the standard of care for Guillain-Barré syndrome. And everybody in Myanmar who gets Guillain-Barré syndrome gets this small volume plasma exchange. They're doing that on the basis of this kind of data, but it's obviously not randomized. The beauty, of course, is at least in Bangladesh, this exchange costs about $500 per patient. It's relatively affordable, particularly if it would show some benefit in terms of outcomes. The second that's moving forward quite quickly is the use of complement blockers in Guillain-Barré syndrome. Shown on the 2 panels down here are human observations from pathologic material from Hopkins, Charlene Hafer-Macco working in Jack Griffin's lab, from material taken back with Dr. Lee from China to show that there was complement activation in both the Aman form of GBS and in the AIDP form of GBS. So the idea was, developed by Hugh Willison, shown here in the center, was to treat GBS with complement blockers. After a long time doing this in his laboratory, he finally convinced first Alexion and then Annexon to do this, and there are other companies considering this. So many people know now that there are a large number of complement blockers. Here are quite a number of them. Different companies are at different parts in the pathway. And even today, this slide is a bit out of date because there are more companies with complement blockers. So the main study was done by the Japanese, published there in 2018. Again, this study has tons of caveats. It's an extremely small study. There are only 30 people who are randomly allocated, and you can see the number that are included in the full analysis set. It's only 24 with a 2-to-1 randomization, placebo or eculizumab on top of their IVIG. The adverse events are pretty equal in both groups. You can see there's one very serious adverse event of intracranial hemorrhage and brain abscess in the eculizumab group. This was thought to be not related. There are no significant differences, and these resolved during the study procedure. Now, the JET-GBS results were powered over here, that is, on the proportion of patients able to walk independently in 4 weeks, and that the eculizumab group should have a lower confidence bound of 50%. That's this diagnostic, this dotted line here. As you can see, it didn't meet the pre-specified number of 50%. The confidence interval went below that, but you can see, and they made a big point of it in the paper, that there was a difference in the proportion of patients able to walk independently at week 4, 61% versus 46%. That's shown here on the slide, but again, you can see the enormous overlap in confidence intervals based on the average functional, the GBS functional grade over time. And again, the proportion of patients able to walk independently is very much overlap, although again, they made a big point out here that there was a difference, but it wasn't statistically significant. So what we learned from the JET-GBS study was that eculizumab, one complement blocker, could be added to IVIG, and it appeared safe in this very small study. There seemed to be an improvement, but again, very small study. Maybe the complement-mediated axon loss that's been shown by a number of people in Guillain-Barré syndrome could be mediated by these blockers. And now there is a phase 3 trial going on. Unfortunately, it is not international, but rather it is a Japanese sole study to replicate this in a larger group to show whether or not eculizumab could reduce axon loss and improve motor function in patients with Guillain-Barré when added to eculizumab. Another company based in California, Annexon, has another blocker that they developed, and they're doing a study in GBS. They've done a phase 1 dose escalation trial. All this work has been done in Bangladesh in 31 patients where ANX005 was well tolerated. They've been able to show biologically that there's full and prolonged C1q engagement and classical cascade inhibition, both in blood and spinal fluid, and this lasts for up to 30 days. The studies are not yet published, and even though I've seen the data, I'm a consultant of the company, what we like to say is that treated patient demonstrated consistent positive trends across key outcome measures and showed significantly reduced levels of neurofilament light chain, a biomarker that in other studies has been suggested to be important in GBS. And so there are phase 2B and phase 3 trials ongoing or planned, but this is the interesting data that they have as yet. Again, a complicated study because it's being done mainly, but not solely in Bangladesh, something that raises questions certainly in the minds of the FDA as to the generalizability of this elsewhere. Another problem with the complement inhibitors, as many people may know, is their cost is unreasonable, to say the least. Eculizumab in America costs between $500,000, $600,000 and $900,000. It's really unconscionable. Now, there's a very interesting antibody called imlifidase. It's an antibody that cleaves the IVIG molecule, as you can see here, takes the business end away. So there you go. There's the IgG molecule. It gets partially cleaved initially and then fully cleaved, and now is essentially inactive. If you give this antibody intravenously, shown here in these two panels, you can take the IgG level essentially down to 0 within a day, because this cleaves every IgG molecule in your blood. If you wait long enough, your IgG will reconstitute, of course, or you could potentially give IVIG. So Hansa Biopharma, who has imlifidase, is doing a phase 2 study in GBS. That is, after you get diagnosed, they'll give you 1 dose of their drug to remove all your IgG, including the pathogenic IgG, but again, it removes all. And then you have to wait till the antibody is cleaved and gone and no longer active, and then you can give IVIG. So this is essentially what I want done by Carlos. If I go in the hospital, you're going to get rid of my IgG by giving me 2 quick plasma exchanges, and then you're going to give me back IVIG, so I either don't get sick or I get the modulating effect of IVIG. This study is ongoing. It got slowed down a bit during the COVID time, but the hope is that in another year or so, the 30 patients that are randomized in this open study will be able to be compared to patients' propensity matched from the IGOS database, and we'll have a good idea as to whether this shows any promise as a treatment for GBS. Now, recently, FcRn blockers have burst on the neurology scene because of myasthenia and argenx. They, of course, promote the degradation of pathogenic IgG antibodies by improving the speed of removal of IgG from the circulation during its recycling in endosomes. But on the other hand, not only does it do that, but other companies have shown that it inhibits T cell activation by stimulating antigen presentation. It blocks cytokines. So there are a number of companies that are quite interested. Let me just show you one slide from one of the companies, Syntimmune. And you can see you can, in a dose-dependent fashion, reduce total IgG levels. You can reduce circulating immune complexes. And so these drugs, of which there are now quite a number, have very interesting ideas as to whether they could be used. For example, in GBS, we could give you dosing of this and reduce your IgG levels down like you were getting plasma exchange to about 50 or so %. We could then also have secondary effects on circulating immune complexes and other actors in the immune system. So we're still trying to convince a company to use these in GBS. One of the difficulties, of course, is that you can't get IVIG as a control arm. You'd have to only get this drug. And so there's certain ethical issues about where you could do it and what the control groups would look like. There are a number of drugs that have somewhat fallen off that are essentially IgG mimetics. That is, starting with observations of Ravitch at Rockefeller, probably 15 years ago at least. These molecules, essentially, he claimed, are the business end of the IgG molecule. That is, they're sialylated, and that's the ones that cause the effect in autoimmune disease. But the difference is that these can be brought and made commercially in great quantities, so it brings the cost way down and allows you to use much higher doses of what I call the business end of the IgG molecule. Again, we're still trying to convince studies to do this, companies to do studies here. So from my perspective, the future looks bright. There are a number of new ideas and trials which are based really on the biology that's been coming out about GBS over the last 20, 25 years. As academicians, as clinicians in the community, we should all be trying to help do these trials. Companies are always interested in people willing to help them because they're going to be the things that help our patients.
So, David, thank you very much. This was a very fantastic review of Guillain-Barré 2022. I am going to give the opportunity to my colleagues, Dr. Maria Isabel Reyes and Dr. Paula Barreras, to coordinate the session of questions and answers.
I will be reading some of the questions. The first one actually is Dr. Angela Gomez. She sent it to me via private chat. She first says thank you for the wonderful talk. And she was asking if you consider that doing more frequent or serial electrophysiological studies may help to classify those difficult cases and potentially, or especially those that are not responding to therapy.
So, it's an interesting question because the idea of so-called electrophysiology subclassifying, which, as Carlos knows, is kind of where I've almost made my entire career, doesn't have really much of a role in terms of treatment at the moment. That is, if I come to the hospital and Carlos sees me and says, geez, David, you have AIDP. I go, okay, great. Give me the treatment for AIDP. He says, okay, we'll give you some plasma exchange, followed by IVIG, just like you asked. And if he said to me, geez, we're really sorry, we think you have a MON, I said, okay, give me the treatment. Well, he's going to give me the same treatment. So I think that the role of electrophysiological subtyping, while should be done, is always of interest. But in terms of a clinical outcome, at the moment, we don't have a reason to say we should do studies every week, we should do this, we should do that. I think the problem is going to be that we're going to want to treat before, in some cases, we know how much axon loss there is, and the studies that show how much there is going to wait 3 or 4 weeks, and we're going to move too quickly.
Entonces, básicamente, a pesar de que hay un interés muy grande porque se haga evolución o se haga una evaluación seria de esos estudios neurofisiológicos para saber el subtipo al cual se está tratando, no hay suficientes datos para que esto realmente vaya a impactar tempranamente en el tratamiento. Espero ser sucinta con la respuesta que dio él.
I'll follow with a question from Melissa Gutierrez that put it in the chat. I think this is regarding the small volume plasma exchange, about how much volume per kilogram do they use. And I guess I'll piggyback that one with, is there a resource or a place where people can learn to do this? Because I think it's probably something that could be key in countries like Colombia, where access to plasma exchange and IVIG is very limited.
Yep. So again, I want to be clear that this is not proven. I don't know whether this is better or not than doing nothing, quite frankly. So before people take it forward, they ought to understand, where the science is. What we tried to see using this small volume, and there are a number of ways you can do this. From a practical standpoint, it always involves, drawing a unit of blood usually, and then you either hang it, or if your blood bank is kind enough, they'll separate it for you. But what we did was try to see if doing it on a practical basis, as you saw on that slide, 4, 5, 6 times a day, you can reach the kinds of volumes that we would normally reach in regular plasma exchange. And that again goes back to the very, very beginning. I said, I don't know whether more plasma exchange is better or less plasma exchange is just as good. So when you're doing the small volume, you're trying to shoot for a total volume along the volumes that were published in the North American and in the French studies.
Bueno, lo primero que el doctor Cornblath quiere que aclaremos es que esta estrategia de hacer intercambio de plasma de pequeño volumen no está del todo probada y que no es claro que sea mejor que no hacer nada o que los otros tratamientos, aunque es prometedor para escenarios como el nuestro. Lo que se está intentando ver con los estudios es si haciendo esa estrategia 4 a 6 veces al día se puede llegar a los mismos volúmenes que se llega con el intercambio de plasma que se hace regularmente. Y la manera de hacerlo sería usar una unidad de sangre, o sea, extraer una unidad de sangre, dejarla colgando hasta que se separe y separar el plasma, o mandarla al banco de sangre si hay un banco de sangre en el hospital y que el banco de sangre la separe, separar el plasma y reemplazarlo con suero o con plasma donado pues sin los anticuerpos. Y el volumen meta es el mismo volumen que se hace actualmente con el intercambio de plasma tradicional.
I'll go ahead and read the third question, even though this was written by Dr. Vargas in English, and it's the following. So regarding the late dysautonomia that is observed in these previously healthy patients, and we observe that sometimes after having the disease, they present hypertension, cardiac arrhythmias, etc. What would you comment on? And then I think I will add a second question. I think that when I was a resident, often when we will be seeing these like severe dysautonomias and like managing those hypertensions with beta blockers and with the fear that that could actually worsen the outcome of those patients. What are your thoughts about that in terms of management?
So I think the very first thing is that when these are occurring a bit late, that's when you have to be extremely careful about sending these people off of monitored units. And there's lots of anecdotal and even some published data about why people die, if you will, in week 3, 4, and in rehab units when they seem like they're getting better from GBS. So I think that when you see somebody with dysautonomia in week 2 and 3, they need to be monitored very carefully. There's no evidence that I know of that any of the sort of, I'll call them cardiac treatments that we might use associated with these would have any negative effect on their GBS outcome.
Translate then, y lo que nos dice el doctor Cornblath es que precisamente esto tiene que ser un signo de alerta en estos pacientes en semana 3 y 4 cuando están listos para salir de la unidad de cuidado intensivo o de la unidad neurológica para rehabilitación, donde si hay estos signos de disautonomía tienen que ser banderas rojas para que estos pacientes sigan un monitoreo muy cuidadoso, porque en las series de casos de muerte asociadas a Guillain-Barré, esta es una de las causas de muerte. Y con respecto a la segunda pregunta, con respecto a los diferentes medicamentos, sobre todo para el manejo de disautonomía, él dice que no hay ninguno que impacte realmente negativamente el desenlace de estos pacientes.
And there's a comment from Guillermo Gonzalez regarding eculizumab use, and it says we're sort of waiting for a guideline that allows to use eculizumab in cases that at onset are very severe. And I think there was a comment following that from somebody else saying that that's not approved. So what are your thoughts about how promising is eculizumab in these cases, and I guess when do you foresee that being used?
Well, I mean, I'm enthusiastic, but it's, golly, sorry, it's neither approved, it's not approved, and the cost at the moment is, I'm just going to use the simple word, stupid. So we're going to have to wait for the Japanese study with the knowledge that in general studies in the Japanese population may or may not translate into other populations because the Japanese are so genetically homogeneous. And so that's going to be a difficult issue. The Annexon studies, which are being done both in Bangladesh and in the Philippines, again, they'll be mostly patients from Bangladesh. And I saw a comment later on about patients with Guillain-Barré syndrome in Bangladesh may be different. So we're going to just have to wait before we really start to use these drugs, a lot of which relates to the lack of evidence and the extraordinary cost.
Comentario del Dr. Cornblath acerca del eculizumab. Dice que él está entusiasta con respecto al uso de estos medicamentos en el futuro en Guillain-Barré, pero al momento no está aprobado, pues aún estamos esperando los resultados de los estudios. El estudio de Japón es probablemente el que va a resultar más pronto, pero él hace el comentario que la población en Japón es genéticamente diferente de poblaciones que han sido más mixtas, entonces la extrapolación de esos datos a nuestra población podría ser limitada, y pues los otros estudios que están corriendo son con pacientes principalmente de Bangladesh, que también podrían ser diferentes, y extrapolar esos datos puede ser limitado también, pero pues tenemos que esperar los estudios antes de que eso se pueda usar en la práctica o se implemente en ninguna guía.
I think for the next one about mild, from a practical standpoint, certainly in America, it's almost impossible not to give IVIG once you make the diagnosis of GBS. I personally could easily make a case not to do it, but to watch closely, because many of the mild people don't get much worse. They get better by themselves, and you've saved a lot of time and effort. But at least in the United States, if you say, we're pretty certain you have Guillain-Barré syndrome, but you're still walking, there's no impairment of your breathing, we're going to admit you in the hospital. Within an hour, the family or the patient or a resident has already written for IVIG. It's just, there's nothing you can get away from it.
Yeah,
Go ahead. Yeah, sorry.
Yeah, I was going to translate that. Había una pregunta en el chat en inglés acerca de los casos leves de Guillain-Barré, si en esos casos leves se consideraría no dar tratamiento, aunque la evidencia es limitada, y el doctor Cornblath dice que aunque él podría argumentar un caso para no tratar a alguien que tenga un caso muy leve y solo observarlo, en realidad, al menos en la práctica aquí en Estados Unidos es muy difícil no dar tratamiento porque apenas se hace un diagnóstico formal, probablemente la familia y por razones médicas casi que inmediatamente se inicia el tratamiento con IVI, con inmunoglobulina. Entonces, pues en la práctica no se hace que no se les dé tratamiento.
So taking this next one about the mortality rates in Bangladesh, I think you actually have to go there to see what the healthcare system is, and you realize that the sickest of the sick get into the study hospital that's the result of all these papers. And so it's not surprising to me that the rate is so high, because people with mild disease don't get into the hospital. I think that's the main thing. And plasmic and small volume plasma exchange is just not routine there. And so nothing's been changed.
Entonces, para complementar la traducción de esa pregunta al doctor Acero, el doctor Cornblath habla que precisamente esas tasas altas de mortalidad en Bangladesh probablemente están asociados al tipo de pacientes que están siendo admitidos al hospital, donde por las condiciones del sistema de salud son pacientes que están muy enfermos, entonces que no les sorprende que estas tasas de mortalidad sean tan altas. And Martha asked if there's a time window for studying the immunomodulation in GBS.
Now, so for plasma exchange, I think the time window could potentially go out to 4 weeks. For IVIG, I think it goes pretty much out to 2 weeks. If somebody's on day 13 or day 14, most people are going to treat. But, the clinical trial data doesn't necessarily support that. And for the last question, I tried to discourage people from giving a second treatment because I don't know that they're valuable. I know they can cause harm, but I personally don't have any convincing data to say that if this patient's worsening, finish treatment, and they're still worsening, that anything I'm going to do necessarily will make a difference. So I prefer to watch and wait and see what their course is like. But I'm in a minority because everybody else is treating.
Entonces la traducción es con respecto a las ventanas. Nuevamente para plasmaferesis él considera 4 semanas. Para inmunoglobulina él consideraría 2 semanas. Sin embargo, por ejemplo, si un paciente está en día 13 o 14, donde ya está fuera de esas 2 semanas, potencialmente o lo más probable es que se vaya a empezar tratamiento. Había una segunda pregunta sobre si dar una segunda línea de tratamiento, y él sigue siendo enfático en que él, a pesar de que hayan datos o los escasos datos que hay, no soportan el hecho de que esos pacientes vayan a tener un mejor desenlace y que se pueden aumentar el número de efectos adversos con esos medicamentos. Entonces, que en su opinión, no.
This has been a very nice session of question and answer. Well, thank you, David, for participating in the meeting, and it is great to see you and to basically receive all of this information for the Colombian group and for other colleagues in Latin America. It's a very valuable teaching activity and educational activity. And again, thank you so much for all things that you have done for all of us.